Yeah.
Hi, Rajni. Hi, Siri,
Yeah.
and the rest of the Stanford colleagues. I'm going to attempt to share my screen right now. And there you go. Hang on a second. And we hopefully you can see hopefully you can see the
Not not
this
not yet.
no, oh no. Uh no, you can't.
Mm, I can't, but
Okay. Oh, wait. Oh, I see. Hang on a sec. Let's try this. Okay. And- Okay.
I see your desktop
Good.
and it's messier than mine. Now I see I see your title slide. Looks great.
Let's see here. That's a pillar of organization. Uh, all right. So thanks very much. And uh, this is my disclosure. I am employed by Rocket and a shareholder. This is the Rocket Pharma pipeline circa 2026, um, which includes several AAV cardiovascular programs as well as several lentiviral hematology programs. Um, I'm going to, and most recently, obviously, an approval of Kresladi for severe leukocyte adhesion deficiency 1. I'm going to start by reviewing the two active clinical AAV cardiovascular programs, because that's likely to be the material that the Stanford colleagues are less familiar with. And then I'll share some of the data leading up to the Kresladi approval, and then of course both the Fanconi anemia and pyruvate kinase deficiency programs, for which Stanford has been a tremendous leader in terms of enabling these therapies to be evaluated. So without further ado, um, I'll present information about Danon disease, the phase one program, which is quite mature, as well as the issues and workarounds that we're encountering on the phase two registrational trial. Danon is an X-linked monogenic disease that arises from pathologic lysosomal associated membrane 2 gene variants. The LAMP2 proteins are critical in autophagy, and in the absence of proficient LAMP2, um, cardiomyocytes in particular become particularly perturbed. They display these prominent sarcoplasmic vacuoles. There's a great degree of myofibrillar disarray. Um, and at the clinical level, this results in a very aggressive and rapidly progressive heart failure. In male subjects, this is predominantly hypertrophic and progressive, um, with a median survival typically to age 20 years, give or take. Um, the female presentation is more varied, both in terms of the cardiomyopathy phenotype as well as in terms of the age of onset. It can affect girls in adolescence, but more commonly arises in young adults. It's still a very devastating disease, as the Kaplan-Meier curve in the upper right indicates, with a lot of premature mortality, either in males during the second and third decade of life, or females 1 to 2 decades subsequently. There are other features, including skeletal myopathy, which are more varied, but by and large not life-threatening. The phase one study enrolled male patients age 8 and above. Patients had to have demonstrable cardiac involvement and some degree of disease symptoms, NYHA class 2 or 3. They were excluded if they had a high degree of neutralizing antibodies or reduced left ventricular ejection fraction. That was a criteria that was implemented prior to the pediatric cohort. Patients received therapy in three different cohorts, two of which were adult cohorts for patients age 15 and above, either at 6.7 times 10 to the 13 genome copies per kilogram, three patients in that cohort, and two at a higher dose, 1.1 E14. And then the two pediatric patients received 6.7 times 10 to the 13 genome copies per kilogram. Although because of a particle cap that was implemented, those patients actually received doses that were closer to 4 to 4.5. The turquoise or teal bars are indicative of patients who continue to be followed on the study and have not had heart failure or required a heart transplant. And that's six of these seven participants. One of the adult patients, the red bar, had progressive cardiomyopathy in the months subsequent to treatment and required a heart transplant approximately 5 or 6 months after therapy. That patient continues to remain alive and doing reasonably well with the transplanted heart. So the green patients are the ones that will be considered valuable for long-term efficacy, and that's six of the seven in the total cohort. Um, this is a table, somewhat busy, illustrating the baseline characteristics of the patients who are anywhere from age 17 to 21 in the older cohort and approximately 12 years of age in the PEDS cohort. Um, some things to note, all of these patients had preserved left ventricular ejection fraction at baseline, except for this one patient, patient 5, who is the one with the rapid progression. Reduced left ventricular ejection fraction is a late stage manifestation in hypertrophic cardiomyopathy um, and is indicative of more advanced fibrosis. Hence, this patient did not uh, derive the benefit from the therapy, and subsequent to that, we made provision to exclude patients with reduced LVEF going forward, both in the pediatric cohorts as well as in the subsequent phase 2. All of these patients had extensive left ventricular hypertrophy. The upper limit of normal of left ventricular mass for an adult is around 225 grams, and that was markedly exceeded by most of the participants, including the pediatric patients. All of these patients had cardiac troponins that were a multiple of upper limit of normal. Troponin is, of course, a measure of cardiac injury, most commonly utilized to diagnose acute ischemia or heart attack. Um, this is a slide that illustrates the progression of the immunomodulatory regimen across the cohorts. When we started out with the adults, we were really just giving corticosteroids at a relatively high 1 mg per kg dose with some sporadic tacrolimus added as liver enzymes were elevated. For the higher dose adult cohort, we used preventative tacrolimus and rituximab. Um, and we had a number of issues in these initial cohorts. One of the patients at the high dose cohort had a grade 4 thrombotic microangiopathy with severe renal failure requiring dialysis temporarily, which fully resolved, as well as severe thrombocytopenia, which also resolved. And then three of these five patients had a grade 3 steroid myopathy, which was determined to be a steroid exacerbation of the underlying Danon disease skeletal myopathy, which also resolved with supportive care and withdrawal of the corticosteroids over time. For those reasons, for the pediatric cohort, We used lower doses of steroids, as well as sirolimus instead of tacrolimus, in addition to rituximab, to optimize um, B cell inhibition as well as kidney sparing agents. Um, Neither of those pediatric patients had thrombotic microangiopathy, nor any substantive skeletal myopathy. Platelets in these patients remained within the normal range, and platelets had been very much a bellwether of some of the toxicities in the higher dose cohorts. Um, from an efficacy perspective, um, of the six patients who are evaluable for long-term follow-up, all of them have evidence of myocardial LAMP2 protein expression by immunohistochemistry, including expression um, at the most recent time points, which, as of this data cut, were anywhere from 24 to 60 months post-therapy, although we have presented some data going beyond that with all patients out to 3 years. These are some of the illustrative IHC panels for four of the representative adult and pediatric patients. The baseline myocardium is evident in this left column, and then one can appreciate that at 12, 24, and time points beyond, in some instances, there is relatively robust staining indicating LAMP2 protein in the myocardium, and this is obviously based on endomyocardial biopsy. Um, in terms of clinical efficacy parameters, and again, this is for the six of patients evaluable for long-term follow-up. All of these patients, by and large, had relatively stable left ventricular ejection fraction. Very importantly, um, there were reductions in parameters of left ventricular mass and left ventricular mass index, which accounts for body weight and growth, with patients demonstrating, for the most part, substantial reductions or stabilization in these parameters. And this was true also for other hypertrophy parameters. Other biomarkers of either cardiac stress, such as natriuretic peptides, or cardiac injury, including the troponins, were also fairly substantially reduced in some cases in the troponins, sometimes going from markedly abnormal to normal range or close to. Each of these patients was symptomatic at baseline and all converted to asymptomatic New York Heart Association class 1. Um, and additionally, there were increases on the Kansas City cardiomyopathy quality of life questionnaire. An increase in 5 points is considered clinically significant, and that was present in each of these patients. And in many cases, a higher increase was identified. This is just a graphic illustration of the troponin levels. And these are some of the patient testimonials, which I'm not going to read, but I think it's safe to say that for these six young Danon disease patients, they were able to resume fairly normal activities. The children were able to attend summer camp and participate in sports. The older patients were attending university, living independently, holding down jobs, which was not something that was anticipated for male individuals of this age with this disorder. So our sense coming out of phase one was that we had identified an immunomodulatory regimen that was capable of uh, uh, controlling most of the immunogenic side effects, and that there was very reasonable efficacy. across a range of parameters, sustained over really 2 to 5 years of follow-up. Um, and that gave rise to the phase 2 registrational study that is underway at present. This is a multi-center international trial. It's a single arm evaluating both efficacy and safety, which was initially planned at a dose of 6.7 times 10 to the 13 GC per kg using commercial grade material produced specifically for this study. Um, Enrolling male patients age 8 and above, also with NYHA class 2 or 3 symptoms, evidence of left ventricular hypertrophy and preserved left ventricular ejection fraction, and elevated cardiac troponins. The primary endpoints are LAMP2 myocardial protein expression by immunohistochemistry and at least a 10% reduction in left ventricular mass. And in the next few minutes, I'll talk about some of the initial safety issues that we encountered in this phase 2 trial that appeared to be in excess of what we had seen in phase 1. Um, and this is using the same immunomodulatory regimen that was utilized for the pediatric cohort of the phase 1 study, including rituximab sirolimus, as well as corticosteroids at a modified dose starting typically at zero point 0.5 to zero point 0.8 milligrams per kilogram. Oops. So, of the initial 4 pediatric and adult patients on this study at this 6.7 E13 dose, 2 of those initial 4 had thrombotic microangiopathy with grade 4 renal failure requiring hemodialysis and severe thrombocytopenia, which fortunately resolved in the weeks and months following the incidents. And I should emphasize that the TMA is something that we had seen really manifesting in the initial week following the AAV infusion. And although there were potential contributing factors, including a concomitant CUL4B mutation in one of these patients, which may contribute to amplified innate immunity, and a lung infection approximately 6 weeks prior to AAV infusion in the other patient. We didn't feel that these were adequate explanations for the high incidence of TMA in this initial cohort. There was evidence for alternative complement pathway activation in both of the patients that had TMA with complement with alternative pathway specific upregulation of C3A, BA, and BB that was demonstrated in Barry Burns' lab at University of Florida. And based on that, we made a decision in conjunction with a number of experts that for the next 2 patients, we would include the C3b inhibitor pegcetacoplan as a component of the immunomodulatory regimen. With the thinking that this would prevent the complement mediated TMA and hopefully make the therapy that much safer. And unfortunately, although the patients did not develop rapid thrombotic microangiopathy, they had a very severe grade 4 capillary leak syndrome that manifested in both subjects at days 4, 5, and 6 post therapy, which with concomitant multi-organ failure. Both patients starting on day 4 had evidence of hemoconcentration with hemoglobins going above upper limit of normal and diminished urine output that then progressed to hypotensive shock and renal failure. I should emphasize that there was no evidence for either cardiogenic or septic etiologies of the shock, and these patients were followed very closely with echocardiograms and other investigations to really understand that. Unfortunately, in one of the patients, the shock was progressive, was not responsive to medical therapy, and this patient required invasive hemodynamic support with ECMO. Um, and as that ECMO was implemented and with other procedures, there was a very large retroperitoneal hemorrhage, which required multiple units of transfusions and then additional organ injury, most notably very severe pulmonary whiteout, which did not resolve over the course of the subsequent 3 weeks. And due to what appeared to be irreversible pulmonary injury in the context of then a secondary bacteremic infection, a decision was made about 3.5 weeks after therapy to withdraw life support, and that patient died. The other patient, fortunately, uh, was able to recover. The very severe um, hypotension uh, was able to be controlled with pressors, but that patient did have additional organ complications, including a very severe liver injury with DIC, each of which resolved, aplastic anemia, which resolved. The only toxicity at present that is ongoing is the renal failure, which does require continued dialysis, although the patient does have urine output. Um, our root cause analysis was that the combination of the AAV and the C3 inhibitor resulted in a severe capillary leak syndrome vascular injury, most likely resulting from diminished C3 mediated AAV opsonization and increased AAV endothelial uptake. Um, these events are really not known side effects of pegcetacoplan, which is approved in paroxysmal nocturnal hemoglobinuria and a number of other complement active disorders, and has not been shown to really cause hypotension, nor have we really seen a similar phenomenon with our PA501 or any number of other AAV agents. So our mitigation for this element is that we'll not be using further pegcetacoplan um, or any other early or proximal complement inhibitors as part of immunomodulatory therapy. But we nonetheless still have this situation where we had a higher incidence of TMA in phase two versus um, phase one. Uh, we know that in the lower doses at phase one, we really didn't encounter TMA in 5 patients at 6.7 or lower doses. We had one of two TMAs in phase one at the 1.1 times 10 to the 14th dose. And then here we had a situation where in 4 patients in the initial phase two, 2 of those 4 had fairly severe thrombotic microangiopathy episodes. So the logical question is, okay, is there something in the water? So we did a very extensive drug product comparison of the phase one versus phase two material, um, and looking at some 20 to 30 different product attributes, going well beyond what's required for release criteria, and found that by and large the products were very comparable. Most of the non-equivalent attributes were due to intentional manufacturing optimizations, um, and again favored the phase two material. The biggest difference really was a higher full particle percentage in the phase two material that was associated with the higher TMA incidence. Well, this is sometimes called a higher full empty ratio, although it's really not a ratio. And this differential was around slightly upwards of 70% in phase two versus slightly upwards of 40% in phase one. And typically, that's considered a good thing because it means you're giving fewer capsids. However, um, it is plausible that because of the higher um, full particle percentage, if a given mononuclear cell or endothelial cell is ingesting a finite number of AAV particles, then that will result in a higher intracellular immune presentation of material that's perceived as viral or foreign DNA, triggering a pathogen-associated molecular pathway response, TLR, and associated response activations. And that may have contributed to the higher TMA incidence. Obviously, that is a hypothesis. It's very difficult to prove, but that was really the only difference that we had seen. And intracellular innate immune activation may be particularly relevant in Danon disease mononuclear cells or endothelial cells, because remember that in Danon disease, the defect is autophagy, and therefore there is impaired clearance of ingested endosomal compartment contents, as the endosomes are not as readily fused to form autophagosomes and lysosomes as there are in other diseases. And unlike most of the other cardiomyopathies, that molecular deficit in Danon is present not just in heart and muscle cells, but in many different tissues in the body. Our mitigation for that is a dose recalibration based on the full particle differential. It's about a 40% reduction to a dose of 3.8 times 10 to the 13 GC per kilogram. And that's the same approximately 40% reduction that we had between the high dose in phase one, where we had 50% TMA, and the lower dose where we did not encounter um, that issue. So the mitigations for the phase two study are the elimination of the C3 inhibitor, a dose recalibration to 3.8 times 10 to the 13. The subsequent three patients are being treated in a sequential format um, with intensive safety evaluations and 4-week intervals between treatments. And then we'll revisit the statistical plan in terms of the initially intended 12 patients with FDA. We've also modified the rituximab to be given over a greater sequence of doses with the same cumulative dose, as well as additional monitoring guidelines with intensified criteria for identifying TMA. Um, and that's really the situation. The treatments with respect to these patients at the recalibrated dose are underway as we speak. And our hope is that we'll have additional safety updates later this year. Um, and obviously, I'll continue to discuss some of the other programs at present, but if there certainly are questions about this aspect of the program, I'm happy to review those at present. And if not,
Yeah,
uh,
I think please.
yeah, I'll give a quicker overview of the PKP2 arrhythmogenic cardiomyopathy program utilizing an AAV RH74. Um, so arrhythmogenic cardiomyopathy can be caused by a number of genetic mutations, including mutations in the plakophilin 2 gene. Um, Plakophilin 2 is a critical component of the desmosome, which is a component of the intercalated disc, which is what enables cardiomyocytes to communicate both electrically as well as structurally. And you can see it here. It's affiliated with any number of other desmosomal and intercalated disc proteins like desmocollin 2 and cadherin 2. Um, and in arrhythmogenic cardiomyopathy, um, the um, disease manifests as both very severe, life-threatening ventricular arrhythmias, as well as progression to heart failure that generally starts off as right ventricular failure with subsequent left ventricular heart failure. And that's why the disease was originally called arrhythmogenic right ventricular cardiomyopathy, ARVC. But then in more recent terminology, because the left ventricle can also be involved, it's now called ACM, but everyone uses terms indiscriminately, and the literature to date has both terminology. ARVC um, typically affects young adults. It can present during adolescence, although median age at presentation is about 35. There's probably some and PKP2 mutations probably account for about 30% of this disorder. There are other mutations as well, and then there are other idiopathic forms. The PKP2 subtype probably comprises somewhere about 2% of all dilated cardiomyopathy, maybe about 50,000 cases per year in United States and Europe. Many of the patients have very serious sustained ventricular arrhythmias. Many of them require implanted cardioverter defibrillators, and there's a very high incidence of sudden cardiac death. Patients are cautioned to avoid strenuous exercise. They receive a lot of different antiarrhythmic therapies, including beta blockers and other agents. Um, and but those therapies don't alter the progression to right ventricular dilation or heart failure. The ICDs are life-saving, but very highly traumatic events. And patients often have a lot of psychosocial abnormalities resulting from fear of the ICD discharge, which is life-saving, but nonetheless extremely frightening. Um, these are the three patients that we treated to date in phase one. They're all adults, um, and all of them were patients who'd had extensive. They all have implanted defibrillators, and all have had extensive either previous or current use of any number of antiarrhythmic agents. Um, all of them had disease symptoms at onset with MYHA class 2 and either normal or mildly reduced right ventricular function. Um, Side effects in these first three patients were mostly mild or moderate, and all of which resolved. We didn't observe any dose-limiting toxicities. However, one of the patients, the first patient 01003, did have grade 3 transaminase elevations, which resulted in an increase in his steroid dose and a prolongation of his steroid and sirolimus treatment, which then were believed to result in a grade 4 pancreatitis and a grade 4 sepsis, which were concomitant. Fortunately, all of these resolved um, to the point where the patient is doing actually very well at present in the months and now years post therapy. But these were nonetheless, this was the one patient who did have high grade serious adverse events. From an efficacy perspective, this is protein expression on Western blot for the three patients in the cohort. And you can appreciate that on Western, two of the patients, and all these patients have some degree of expression at baseline because it's a heterozygous disorder. But in these two patients, there's increase in protein expression on Western blot. That's also illustrated in the panel on the right. For this patient, 1003, even though we didn't see expression on the Western blot increase, on immunofluorescence, it was evident that starting at 6 and then especially at 12 months, there was a higher degree of appreciable PKPD protein, as well as increases in some of the other intercalated disc and desmosomal proteins coherent to and desmocolin evident at 6 and especially at 12 months. And that's particularly illustrated on this immunofluorescence slide, in which we're seeing things both at baseline, 3, 6, and 12 months. Plakophilin 2 is illustrated in the red row. And you can appreciate that we don't see much of an increase at baseline at 3 months. We do see more at 6, and then especially at 12 months, it's appreciably higher, as is one of its partner proteins, cadherin 2. Very importantly, on the immunofluorescence merge sequence, you can appreciate that the yellow tells you that they're all co-localizing, so that these proteins aren't just upregulated, but they're going to the same part of the cardiomyocyte, which appears to be the cardiomyocyte junction, the intercalated disc. So they're getting where they need to be. Um, and we've also seen some of these increases in the sibling proteins in the other study participants, including 1001 and 110. I'm not going to go through these in the interest of time. In terms of clinical manifestations, um, patients have had either stable or improved right ventricular function on echocardiogram. Patients have reported improvements in two of the patients have reported improvements in KCCQ quality of life, although actually at a later follow-up, this patient also had improvements with concomitant improvements in symptoms such that they are NYHA class 1, absence of symptoms. We've seen reductions on 24-hour rhythm monitoring in premature ventricular contractions across all patients. And then for the one patient who had non-sustained ventricular tachycardia on rhythm monitoring, that also appeared to resolve. Um, and then in the patient who had T-wave inversions on electrocardiogram at baseline, those also reduced in terms of number. That also is now at a later follow-up reduced in this additional patient as well. T-wave inversions are indicative of retrograde repolarization and are a risk factor not only for arrhythmias but also for heart failure progression in this disorder. So our conclusions in this phase 1 study is that this is a therapy that we, for the most part, were able to give without dose-limiting toxicities, although one patient did have SAEs, and we will be treating additional patients at this dose before we can proceed to phase 2, either at this or a modestly lower dose. We had very nice protein expression going well beyond just the protein of interest with the localization at the cardiac desmosomes and improvement or stabilization of any number of arrhythmic, electrocardiographic, and echocardiographic parameters, as well as some degree of symptom resolution. And that's the PKP2 program as well. The BAG3 cardiomyopathy program is one that's going to be starting. The trial is open and enrolling. This is a dilated cardiomyopathy. BAG3 is a protein that has a very broad range of roles within the cardiomyocyte. And these are patients that have fairly extensive heart failure, typically during young adulthood, with fairly high progression. We don't have any clinical data yet, and I'm not going to go into the preclinical data in the interest of time. Moving over to the Lenti portfolio, which is something that many of the Stanford colleagues may be familiar with. This is the one lenti program that was not conducted at Stanford in severe leukocyte adhesion deficiency 1. I'll share some of the data on that. Um, LAD1 is an integrin-mediated disease caused by ITG mutations. ITG encodes for CD18, which is a critical part of um, the an integrin on leukocyte surfaces that mediates adhesion to endothelial surfaces. The CD18, CD11 complexes enable leukocytes to arrest on endothelial surfaces, which is a critical step before they can then migrate to sites of infection or inflammation to mediate those processes. Um, in the absence of functional CD18, CD11 complexes, this adhesion is impaired, and this results in very substantial immunodeficiency. Specifically, patients with severe LAD1 typically have less than 2% of CD18 and or CD11 moieties on neutrophil surfaces, and then have very, very severe, frequent, recurrent bacterial or fungal infections and impaired wound healing, um, and very, very high mortality early in life. Um, this is a survival curve from Alan Fisher's initial 1988 publication, where you can see that in the absence of transplant, the severe patients, very high mortality by age 2, and very, very limited survival beyond age 5 or age 10 in the absence of transplant. Moderate patients have somewhat higher expression and somewhat longer survival, um, but nonetheless, substantial ongoing infections and inflammatory complications. Allogeneic transplant is potentially curative. It's limited by donor availability. And even in recent series, there's a very high risk of graft versus host disease and graft failure, likely as a result of the ongoing hyperinflammatory phenotype that afflicts these patients. Um, the RPL201 Kresladi is autologous CD34 cells that are transduced with a lentiviral vector encoding for wild type ITGB2 with a chimeric promoter that's intended to be very specific for human myeloid lineage cells. This is a sequence that I think the Stanford colleagues know very well in terms of GCSF and plerixafor mobilization, apheresis, transduction over 2 to 3 days. This is a cryopreserved product that is infused with busulfan conditioning, targeting the AUC of 65 to 75, with ustekinumab, the IL-17, IL-23 antibody administered in the weeks prior to therapy. The pivotal study was an adaptive phase 1/2 trial, which evaluated 9 patients with severe LAD1. Those patients are now followed anywhere from 3.5 to 5.5 years. All patients had to have less than 2% neutrophil CD18 or CD11 neutrophil expression, documented mutations, and some degree of either family history or prior infections. And in the interest of time, I'll cut to the efficacy. All of the patients were from either the US or any number of other countries around the world. The oldest patient was age 9. Most of the other patients were younger, including several who were under the age of 2. Patients received between 2.8 and 10 million CD34 cells per kilogram. Um, Here's the Kaplan-Meier curve of transplant, allogeneic transplant-free survival, and it's just a straight line. And you can appreciate the different patients anywhere from 3 to 5.5 plus years out. This would also be the same for overall survival. All patients are alive and well and living a relatively normal, healthy life. Actually, the oldest patient, who is now the oldest patient is now 5.5 years out, now has her driver's license. There were no incidences of graft failure or GVHD in this 9 patient cohort. Um, this gives you a sense of the CD18 neutrophil expression going out over time. There are a couple of dips that I think are more artifactual, as in each case, when that was identified, then the values came back to more of a normalized level at subsequent assessments. And the same was also true when we looked at CD11A, the codimer, which is indicating that not only is CD18 getting into the neutrophils being produced and getting on the surfaces, but it's codimerizing with its partner CD11 moieties. Um, we've seen very dramatic reductions in um, infection-related prolonged hospitalizations as well as significant infections. The red bars illustrate the annualized incidences of these complications in the years and months prior to study participation, and then the gray bars in the months after hematopoietic reconstitution. Um, from a side effect profile, the table illustrates the most common side effects, which are really mostly related to the conditioning busulfan and which resolved. One subject had a grade 4 pulmonary hypertension, which manifested about 3 months after infusion and fully resolved, fortunately. This was a patient who had a concomitant aortic arch malformation, which caused tracheal compression. This patient had a tremendous number of pretreatment leukemias, including a very substantial bilateral leukemia in the interval between cell collection and IP infusion. Fortunately, that grade 4 pulmonary hypertension resolved, and then the patient was able to have a successful aortic arch surgical correction without any substantive wound healing complications, which also indicates a phenotypic reversal for a kid with severe LAD. Um, the integration site analyses over time demonstrate very good um, clonal equality, as illustrated by the low Gini index sustained over time, as well as a high diversity, high Shannon index over time. And then you can appreciate really almost at all assessments at any given time point, highly clonal patterns of diversity that are sustained. Um, so our conclusions for severe LAD-1 were really every patient in the cohort met the primary endpoint, but more importantly, all patients appear to be alive and well without transplant, 3 to 5 plus years of follow-up with reductions in infections um, and really normalized integrin expressions on neutrophils with sustained and stable neutrophil integrin expression and vector copy numbers. So it's a pretty nice story, and we're happy that Kresladi was FDA approved back in April of this year. And we're hopeful that we'll be able to have some of the initial treatments commercially, ideally later in this year. So that's a pretty heavy whirlwind in the first 54 minutes. Um, Obviously, I'm hopeful that many of you are quite familiar with the Fanconi data, which continues to get better over time. Obviously, Rajni has been a huge part of that program, and obviously also Ami has been a critical part of the PKD story. Smaller program, still only phase one data, but super encouraging. I don't know if this would be a good time just to have a discussion and questions, or if you want me to hit some Fanconi and PKD highlights. Let me know
Yeah.
what would be most helpful.
Jonathan, thank you for as you that presenting that uh, broad data. I think it might be nice to leave a few minutes for questions. I do appreciate you highlighting Stanford's contributions to the FA and PKD programs. I know we're proud of our contributions and are excited about when we come out of this funding winter to figure out how to continue to develop those programs. There's one question in the chat that goes back to your AAV and the interesting and well, unfortunately interesting finding of early inhibition of the complement pathway synergizing in a negative way with the AAV. And so the question is would you recommend proactively testing patients before or after dosing with C3A, BA, or BB, or anti-C3A, BA, BB?
Oh, gosh,
How are you thinking? I guess a more broader question is how are you thinking about monitoring the complement pathway as people receive AAV gene therapies?
yeah. So one of the things that we're doing in the Danon program is uh, we test for a panel of genes that have been associated with higher propensity for complement activation. And I think a lot of this is work that was guided by some of the Cincinnati Children's
Hmm.
activity, specifically in transplant,
Right.
uh, hematopoietic transplant mediated TMA. And if patients have pathogenic or likely pathogenic variants in any number of this, it's more than a dozen genes. It includes um, complement factor H, complement factor I, CD55. It's a whole panel that we do. If they have any mutations in those genes, then they're excluded from participation. Um, and additionally also if they have very low levels of um, complement factor H or abnormal AD, Adam TS 13. So
Hmm.
we're
Hmm.
trying to exclude patients at the highest risk. I think that's the most important thing. We monitor patients very carefully in the initial 2 weeks after therapy with daily labs and that includes C5b9 as well as platelets, and we
Okay.
found that the C5b9 and platelets are really the best indicators of nascent TMA. And if we have a clinical monitoring team that comes along for the ride and is looking at this every day, making recommendations as to whether or not we should implement rescue eculizumab, which is the C5b inhibitor, which can be given safely in these patients. Um, and I think those are some of the critical things. One of the other things we recognize now with the help of Barbara Sullivan at Ultragenics is that the absolute monocyte count is actually an excellent surrogate for C5b9. And so we monitor that. Obviously, we're looking also at the urine for protein, peripheral blood for
Right.
schistocytes, LDH, et cetera.
Right.
And then we are getting some of the more rarefied complement subtypes, and we look at all those in the patients, but we can't really do that in real time. That's really more of a post hoc batched analysis that we do University of Florida with Barry Byrne and the help of Kristen Coleman and Manuela Corti in Barry's lab.
Thank you. That's great. I think complicated biology, but and we'll learn a lot in complicated monitoring going on. Um,
Yeah, this is very exhaustive list. And, in transplant, as you said, Jonathan, we are very familiar with this and the algorithms to diagnose and all. But what you have said is exactly how we go about it also. And at ASGCT, there was a beautiful talk on the last in the morning on AAV viral mediated TMA and liver and cardiac injury, which pointed out to some of these monitoring, mm, mm, programs.
Yeah. And I would say that I think really importantly, as much as we are, all of us are inclined to try to think of things in, systematic global ways. There is a lot of nuances here, and what we're only really now learning is relatively whether or not AAV9 versus AAV RH74 may be more
mhm.
likely to be provocative of TMA. But
Yep.
one thing that I think is really, really important to emphasize that we didn't appreciate going into this, but we do now, is that Danon disease itself may be a condition in
Yep.
which AAV is more TMA provocative than it would be in other diseases. In other words, because that LAMP2 deficit is present in many different tissues and organs, it's present in monocytes and probably in endothelial cells, and that may render um, Danon patients more susceptible to this than patients with any number of other cardiac or musculoskeletal disorders. And we've got a number of in vivo experiments underway to try to evaluate this. And we're trying to also figure out the most efficient way of evaluating that the contribution of LAMP2 deficiency in an in vivo setting beyond just endothelial cell lines, but we will be uh, trying to investigate this as thoroughly as possible. But really, I think it a lot of it has to do not only with the vector type and vector dose and the immunomodulatory regimen, but also the underlying condition.
I think that's right. Any other questions for Jonathan or comments? Well, I'll make one comment. I think the Adentis XLMT experience is similar to what you're describing, that we were treating one organ and we realized that there was a sensitivity in another organ. And your comment about looking broadly across the vector, um, the underlying disease, the potential manifestations in other organs and sensitivities, the immunomodulatory regimen, when it's given, how it's given, are all things we're going to learn from the field and from Rocket moving forward. So, um, thank you, Jonathan, for taking the time to present the progress that Rocket is making across all of these diseases. We hope we'll have an opportunity to invite you back in the near future to give an update. In the meantime, let us all give a round of applause.